Good morning. Thank you for joining us. My name is Shannon McConville, and I am a researcher with the Public Policy Institute of California. Thank you for tuning into our program today, featuring the findings of a new PPIC report, How Hospital Discharge Data Can Inform State Homelessness Policy. I'd like to thank the California Healthcare Foundation for their support of this research and today's event. I also want to acknowledge my co-authors, Hemal Kanzaria, Renee Shaw, Maria Raven, and Margot Cashel. For today's program, I will present key findings from the report and then invite my co-author, Dr. Hemal Kanzaria, to join me in a discussion of our main takeaways and also answer questions from our audience. If you are interested in learning more, the report and a policy brief, as well as the slides from today's presentation, are available on our website at ppic.org. A couple of housekeeping items before we start today's program. As a reminder, PPIC is a public charity and does not take or support positions on any ballot measure or legislation, nor does it support, endorse, or oppose any political parties or candidates for public office. Towards the end of today's program, we have set aside some time to answer audience questions. Please send your questions along with your name and your organization to the email address on the screen, ppiceventquestions@gmail.com. And with that, I will start my presentation. In recent years, state policymakers have taken a more active role in addressing homelessness. With billions of dollars in state funds going towards housing and homelessness services, along with funding from federal COVID relief aid, public investments targeting homelessness have never been greater. However, a lack of information hinders statewide policy efforts and makes it difficult to assess the impacts of policies and funding, which is why we did this study, to assess how hospital discharge data could add additional sources of information to this critical area. So most of the information we do have on the scope of homelessness in California comes from local agencies called continuums of care that coordinate homeless assistance services and funding in communities across the state. Another potential resource for statewide data on Californians experiencing homelessness is hospital emergency department data. All licensed hospitals must submit detailed information to the state each year for every ED encounter and hospital admission. In 2019, the emergency department discharge data included an indicator for the first time to identify people experiencing homelessness. In our study, we wanted to investigate the potential role of this data to broaden our understanding of people experiencing homelessness across California. So we start with some of the information that we do have about Californians experiencing homelessness. These are trends in annual counts of California's homeless population. These numbers come from what we call point-in-time counts, which are conducted by these local homeless assistance agencies, typically on a single day or two in January or February of each year. You can see we did see an uptick in the last several years. Since 2016, the homeless population grew by about 35% to be about 161,000 people. Though the most current statewide data we have is from the beginning of 2020, right before the pandemic took hold. The 2021 counts were not done because of the risks of COVID. The other thing I would note here is, you can see about 70% of Californians experiencing homelessness are unsheltered, which means they are living in the street or places not meant for human habitation, rather than in emergency shelters or temporary housing. And the number of unsheltered has also risen considerably in line with the total number of individuals experiencing homelessness. Most counties have actually released their 2022 counts conducted at the beginning of this year. Those statewide counts are still not available. Los Angeles just released their 2022 homeless count earlier this month and reported over 69,000 individuals were experiencing homelessness. This is an increase of about 2,700 people, or about 4% compared to their 2020 counts. Other counties reported larger growth in their homeless population. For example, Sacramento County increased their homeless population increased the most by almost 70% between 2020 and 2022. Other areas that saw sizable increases include Alameda and Contra Costa counties. And this compares to other areas in the state, like San Francisco County, that recorded a decline of about 5%, and Orange County, that reported an 18% decline in their homeless population in 2022. And despite these point-in-time counts being the most often used or cited metrics to define the scope of homelessness, they really are fairly limited and aren't of much use in letting us kind of monitor changes in homelessness and assess policy impacts. So hospital emergency departments are frontline providers for Californians experiencing homelessness. They're open 24 hours a day, 365 days a year, and are required by federal law to provide medical screenings and stabilizing treatment to anyone who seeks care, regardless of their insurance coverage, their ability to pay, or other circumstances. A new state law that went into effect in 2019, SB 1152, created new requirements for hospital EDs to expand and document discharge planning for patients experiencing homelessness. SB 1152 really heightened awareness and brought more focus to screening patients for homelessness in the hospital ED setting. And as part of our study, we interviewed hospital staff working in patient registration. We interviewed ED nursing staff along with social workers from 5 hospitals across the state to understand more about how they collect this information. Everyone we spoke with described updates to their processes and procedures for screening and recording information on patients experiencing homelessness. But they also really highlighted the challenges of asking people about their housing status and being able to identify who may be experiencing homelessness. So at the hospitals we interviewed, it was often patient registration staff who initially gather information and screen people for homelessness, usually as they are asking questions about a patient's address. In some hospitals, their data systems would flag if someone provides an address that is an emergency shelter. But most patient registration staff we spoke with indicated it was a really sensitive issue, and patients often didn't understand why they were being asked these questions and may not provide accurate information because of dignity, because they were embarrassed, because they didn't want to disclose that they were experiencing homelessness. Overall, what we learned from our interviews was that identifying whether a person is experiencing homelessness is not a simple checkbox question like some of the other data that's gathered. And often people who have more visible signs of homelessness, like a lot of bags or belongings with them, or may have inappropriate clothing, were more likely to be recorded as homeless. So the first part in our analysis of the ED data was to see how it compared to data that is collected by local homeless assistance agencies on the clients that they serve. So the information collected by homeless assistance agencies is done at the local level and is a requirement of receiving federal funding for homelessness services. Recently, the California Interagency Council on Homelessness, the state level agency responsible for coordinating the state's homelessness response, has brought together data from these local agencies to provide more state level information. And we've used that information again to compare it to what the emergency department data shows us. What we see here is more men and middle-aged and older adults and fewer children and women are identified as experiencing homelessness in the hospital ED data relative to the homelessness services data. And these differences may be due to families with children being prioritized through different programs to receive homeless assistance from local agencies. It's also likely a function, as I mentioned, of who is most likely to be identified as homeless in the ED setting. So now we move into kind of examining the discharge data. So we focused most of our analysis on the 9 million ED visits made by adults ages 18 to 64 in 2019. About 8 million of those visits were what we refer to as outpatient ED visits, meaning that the person was treated and released the same day. About another million ED visits result in the patient being admitted to the hospital. And so what we found was about 4% of outpatient ED visits were by people identified as experiencing homelessness. That share doubled when we looked at ED visits, where that resulted in an inpatient admission to the hospital. There, about 8% of admissions from the ED were for homeless patients. And here, when we look at those ED visits that are made by patients identified as homeless, we see that the majority, about 60%, are at nonprofit hospitals throughout the state. Though this is slightly less than the 66% of total ED visits at nonprofit hospitals. I would say nonprofit hospitals are the largest group and represent the majority of hospitals in operation in California. In contrast, we see that county hospitals provided nearly 20% of ED visits to homeless patients, and that compares to their total statewide ED volume, which is about 10% of all ED visits in the state. 12 large counties, mostly in the Bay Area in Southern California, operate public hospital systems. We also found that hospitals operated by the University of California also provided a higher share of ED visits for homeless patients compared to the share of their visits, of their total statewide ED visits. Some of these differences that we see by ownership type are likely driven by location. Counties and UC hospitals tend to be in larger, more urban areas of the state where more homeless people may reside. But also reflects the primary role, especially of county hospitals, their part in the state's healthcare safety net system. So we also looked at ED visits at hospitals across regions of the state. Here we found that Bay Area, Los Angeles, and other Southern California, which includes Orange and San Diego counties, that hospitals in these regions reported higher shares of ED visits by patients identified as homeless relative to their shares of total statewide ED visits. In contrast, in the Central Valley and Inland Empire regions, hospitals reported smaller shares of ED visits by patients experiencing homelessness compared to their share of total statewide ED visits. And so finally, we looked at some of the additional information that is included in the discharge data. So the discharge data includes a primary diagnosis and up to 24 additional diagnoses for every ED visit that happens. We used all of this, all available diagnostic information to look at what homeless patients were being treated for in the ED and how that compared to ED visits by other low-income patients that were not identified as homeless. Here we're looking at some common chronic conditions. We found that higher shares of ED visits with diagnoses for hypertension, COPD, hepatitis, and liver disease were identified among patients who were homeless. We also looked at behavioral health conditions. These include mental health conditions and substance use disorders. Consistent with other studies and research, we do find much higher shares of diagnoses for mental health conditions and substance use disorders for homeless ED patients compared to other low-income ED patients. Nearly 40% of ED visits by patients identified as homeless had a mental health condition diagnosed, compared to about 15% of ED visits among low-income adults who were not recorded as homeless. We also see relatively high shares, about 30% had a diagnosis of a drug-related disorder, 20% an alcohol-related disorder. And when we drill down to look more at which mental health conditions were being diagnosed, schizophrenia was the largest or the main diagnosis, and almost 20% of ED visits by patients identified as homeless had a diagnosis of schizophrenia. And here we're looking at, so here we're taking a more patient population focus, and we're looking at the share of people who are admitted to the hospital as a result of an ED visit across the spectrum of ED use. So what we see here is that we see higher admission rates among people experiencing homelessness across the spectrum of ED use. And this really highlights the higher morbidity that is documented among people who are experiencing homelessness. We can see even for patients with relatively low ED visit rates, that many of them, if they are identified as homeless, are admitted to the hospital. And at high levels of ED use. And again, high levels of ED use, people who are visiting the ED 7, 10, more than 10 times over the course of any year, likely have pretty high healthcare needs, and also it could represent barriers to accessing care in other settings. But even at that, say more than 10 ED visits in the year, we still see homeless patients have higher shares of a hospitalization. About 76% have been admitted to the hospital, compared to about 58% for low-income, heavy ED users who are not identified as experiencing homelessness. So a quick wrap up. In our analysis, we examined about 400,000 ED visits by patients who are identified as homeless. This is most likely an undercount of the care provided in hospital EDs to Californians experiencing homelessness. Linking this discharge data to other resources, administrative data resources like homeless services data or Medi-Cal data, could really further add to our knowledge base. And as more policy efforts and funding are focused on addressing homelessness in California, we really do need more sources of actionable and comprehensive information in order to guide the decision making. Thank you. Let's see. Oh, I'd like to now welcome my co-author, Dr. Hemal Kanzaria, to join me. So you're reminded that you can submit questions to the email address on the screen. Please do include your name and organization. And that email address is ppiceventquestions@gmail.com. So Dr. Kanzaria, thank you for joining me.
Good morning, Shannon. Thanks so much for having me.
Yeah, of course. Dr. Kanzaria is an associate professor of emergency medicine at UCSF. He is also a practicing emergency department physician at Zuckerberg San Francisco General Hospital. So now we'll start our discussion. So Dr. Kanzaria, much of your experience and research is focused on how hospital EDs often need to address patients' social needs in order to provide effective medical care. Can you talk about your work as an ED physician treating patients who are experiencing homelessness?
Yeah, absolutely. So, I mean, I feel really privileged to be able to be an emergency physician. I work at ZSFG, which is the large county hospital in San Francisco, and a little bit about the hospital system. So it's a level 1 trauma center, which means we're sort of set up to take care of, any and all patients with traumatic injury, whether that's from a car accident or a gunshot wound or a fall. We are also a teaching institution affiliated with the University of California, San Francisco. And we serve, a patient population with complex medical and social needs. We see in the emergency department about 150 to 175 patients per day, and 2/3 of our patients are Medicaid beneficiaries. And as we showed in the report, about 1/4 of our patients are experiencing homelessness. And I love, being an emergency physician because I love the mission of emergency medicine, the ability to sort of be there for any patient at any time for any reason, whether that's a heart attack or whether that's, food insecurity. But I also think practicing in this healthcare environment, sort of, you see some of where our patients are challenged and where our society is sort of failing, or some of the shortcomings in terms of what we sort of see in the emergency department. And so, I'm thinking about patients who come in with a crisis related to their diabetes because they can't afford their insulin, or patients who come in with depression because it's hard to access outpatient mental health services, or patients who sustain a gunshot wound related to our sort of, firearm sort of policies in America, or patients who come in with asthma. I'm thinking about, I can keep on caring for patients with asthma and give them medicine, but until I can help them access or be in a smoke-free home, until I can also help them afford their medication, until I can also help them get transportation to their outpatient clinical appointments, I'm limited in terms of how I can really help advance our community's health and our patients' health. And so I'm just trying to paint a picture that, really health is more than healthcare. And that's very clear in my practice in emergency medicine at the General. We can't just be thinking about prescriptions and follow-up visits. we really, we have the opportunity to focus on sort of the underlying social, environmental, economic, and political factors that contribute to our community's health and our patients' health. And I think that is a really important opportunity for advancing sort of community health.
Yeah, that's great. Thank you. You mentioned about, we found about 25% of ED patients at the General are identified as experiencing homelessness. Can you describe how that can impact the day-to-day flow, the operations of working at a hospital at a hospital ED? What are some of the challenges it presents kind of in that setting?
Yeah, of course. So as I mentioned, we care for a pretty vulnerable patient population. I think you commented on this in your sort of presentation today, but our patients have a high degree of morbidity, of early mortality. There's an increased need for hospitalization, and that's related to many of their chronic conditions. And it's also potentially related to homelessness specifically. So of course, the emergency department and hospital are very well equipped to take care of patients' medical diseases, but we would like to, it would be great to have easier access to supporting our patients on housing. Housing is healthcare. And so sometimes as a clinician, we're faced with hard choices around, resource utilization. And, I give you a couple other sort of common patient examples. This is sort of everyday examples. Someone comes in with a bad ankle fracture after a fall, for example. And, most people with ankle fractures, they can follow up with an outpatient orthopedic surgeon. They can get surgery if they need to or not, but they can also get sort of physical therapy. But you can imagine if you are unhoused, trying to navigate sort of our system, trying to navigate access to outpatient care with all of your potential life belongings with an ankle fracture, that's very challenging. Taking another patient example that comes up commonly, someone who comes in with an infection of their lower extremity. Again, Shannon, maybe if it were you and I was seeing you, I would give you antibiotics and I would send you on your way. If I'm caring for someone who's experiencing homelessness and they don't have a place to keep their leg up to help reduce sort of the swelling and the infection, they may be financially insecure and so unable to afford medicine and are unhoused. Housing really impacts everything we do. Housing is healthcare. And so in those situations, I think as an ED doc, I am faced with making a decision about, whether this individual is so sick that they need to be in the hospital or they're safe to receive services in the community. And sometimes we do have to keep people in the hospital more for their social needs than their high acuity medical needs. And that certainly has impacts on our day-to-day operations and our flow. So, very clearly during the COVID pandemic, for example, it became very, very clear that our inpatient sort of medical surgical beds and our ICU beds, those are really scarce resources. And in those beds, like the hospital is set up to take care of the highest acuity medical illness. And sometimes, though, if we need to use them to support the patient in front of us related to their social needs, that has downstream implications for everyone. Patients lose autonomy when they're in the hospital. They are at increased risk of hospital-acquired infections. But there's also some moral distress at the staff level in terms of feeling like you want to do your best to help that individual in front of you, and knowing that someone who's unhoused has sort of deleterious health consequences. I think it puts staff in a very challenging place, and we heard that during this study in terms of when we interviewed staff and tried to get a sense of how they can support patients. Again, housing is something they would like to be able. I would like as a doctor to be able to prescribe housing. That would be more powerful than any medication that I can prescribe. And so we're sort of charged with this balance of how do we take care of the individual patient in front of us, while also taking care of our community that needs access to those inpatient beds. And so that in that way, it has flow impacts in terms of there's not enough housing for the volume of patients that need that service.
Absolutely. And we did, especially from the nursing staff that we interviewed and social worker staff, hearing the challenges that they faced and feeling like they didn't have enough resources or they weren't able to connect their patients to what they needed, that really impacted their ability both to do their job, but also just kind of the stress and other parts of their, it made their job harder, right, when they weren't able to do that. So one of your other roles at the hospital is the medical director of the Department of Care Coordination, which is trying to understand how we can make connections for folks. But can you talk more about your work with that department? What do you see there? What are you, doing to try and to facilitate some of those connections?
Yeah, so as the medical director of the Department of Care Coordination of the General, I get again the privilege of getting a chance to collaborate with a multidisciplinary team. So I work very closely with our social service staff, with our utilization management staff, with case management staff, and we're really trying to think about, how do we provide patients the right care in the right place at the right time? And at the end of the day, we're trying to provide high quality care as well as being stewards of our resources. So it gets at, thinking about the correct level of care for each client, each patient that we're serving, supporting patients both on their medical and their non-medical needs to get safely to the next step in their care continuum. So sort of thinking about what the post-hospital course will look like. That ends up requiring a lot of collaboration, both with the hospital setting, and we're lucky to be within a Department of Public Health. So thinking about what other resources are available to our patients within the Department of Public Health, but then also thinking about sort of factors that impact health outside of the healthcare system. So, there's many examples of this. I think a really nice example is the social medicine team that's based in our hospital system. So thinking about how we meet patients' medical and social needs in parallel, how we understand patients' self-identified needs, and how we support them in advancing sort of their health. And, I can talk through many different examples of this, but for the patients I was mentioning, like the patient who comes in with an ankle fracture who's unhoused, these type of teams think about, okay, well, how can we get that individual access to transitional housing? How can we get that individual free medication so they don't need to pay out of pocket? How can we support that individual with activities of daily living? So, referring patients to programs like in-home support services, if they do have access to housing, helping set up Meals on Wheels. So thinking about their food needs, their transportation needs, and sort of setting that up for them so that they have transportation to their next step. That takes a lot of collaboration sort of with a diverse team, both in the hospital as well as outside the hospital.
That's great, thank you. And so kind of as part of that, can you talk some more about kind of working with other county agencies and departments? Here I'm thinking about, say, some of the local homeless assistance agencies, or maybe county specialty mental health services, but needing to, kind of coordinate services across a lot of different departments or agencies.
Of course, and we certainly, that's every day part of our work on every patient. And so very commonly we are working with San Francisco Health Plan, which is our managed Medicaid health plan in San Francisco, to think about access to community long-term care, community skilled nursing facilities. We are increasingly with CalAIM now, interfacing with them to help patients get access to case management services. For specialty mental health care, again, we are fortunate to be able to work with our behavioral health services department in the Department of Public Health. And again, thinking about patients who need like a board and care level of care, or RCF, RCFE, they're called, getting access to those beds, access to treatment beds for substance use disorders, for example. But even within our own Department of Public Health, we are privileged to be able to work with our medical respite centers, our psychiatric respite facilities, and really, again, trying to meet patients' needs in the level of care that's that's appropriate, that's high quality for them, while saving a hospital bed for people with really dire sort of acute medical needs. Outside of the health system, I think, again, there are many collaborating agencies. And so, the social medicine program I talked about before, we do work with the departments of housing and homelessness and supportive housing, and are trying to assess patients using the adult coordinated entry process that we refer to in the report, to help people get sort of scored for housing and then prioritized for permanent housing. We also commonly work with, the Human Services Agency, including the Conservator's Office when that's necessary. And we do have sort of weekly multidisciplinary sort of rounds on our most complex patients, where we have, representatives from the behavioral health system, from the Human Services Agency coming and discussing cases with us to help support our patients.
No, that's great. Well, we have maybe one more minute in our discussion. I was wondering if you had, just any kind of last or perspectives for kind of what policymakers might need to know, what additional information or resources are needed in order to kind of do what you do every day.
Well, I mean, I think there's two points. So one is around sort of data, and I think our report sort of talks about this, is the discharge data from the hospital or the emergency department. That's sort of one piece of really important data, and it needs to be put in the context of the other data that we have to help sort of triangulate our understanding of homelessness across the state. I think that there's an opportunity to sort of advance our understanding of our community, recognizing patients' physical needs, their behavioral health needs, their social needs, and understanding what those needs are so we can meet them. From a policy level, I think that there are myths about homelessness, and just to be really explicit, like homelessness is due to structural factors. It's due to poverty, income inequity, rising housing costs that make it very challenging to afford housing, structural racism. And so when we're thinking about how to overcome homelessness, we need to be addressing these underlying structural factors that are contributing to homelessness, and also remembering that we know the solution to homelessness. The solution is housing. We need housing, and that will help resolve the problem of homelessness. So those are sort of the things I'd want policymakers to know, and that I see as part of my role as a physician and advocate, but I think we all can sort of work towards that together.
That's great. Thank you so much. So now we're going to go ahead and turn to audience questions. As a reminder, you can still submit your questions to PPIC event questions@gmail.com. And it does look like we have a few questions that have come in. So the first question for you, Hemal, is from Michelle Schneiderman at the California Healthcare Foundation. And so her question is, what's needed to help hospital staff learn to ask about housing status in a trauma-informed way that imparts the importance of the question and connecting it to care?
Great. Thanks, Michelle. Always nice to see your name. Thanks for that question. So there's definitely an opportunity, and I think our staff, struggle with talking about sensitive topics, especially our Shannon mentioned, our registration staff are tasked with screening patients for housing, and patients may be wondering sort of why that's done. And so I think there's an opportunity, and we definitely try to support our staff here, and I know across the state, around trauma-informed care, around relationship-centered communication. So some of the communication tools we have to make the experience in healthcare less traumatizing. I would also say something I mentioned briefly in the discussion is really focusing on patients' self-identified needs. And so for me as an ED doc, that means sitting down with my patient and asking them, what is the thing that they most need help with today in that moment? And so they may have a physical, chief complaint, but they may also, and we commonly hear, concerns around access to food, around financial insecurity, around housing. And again, I think it's our sort of opportunity and our privilege to partner with our patients on that. In a lot of our sort of work, I think about allowing and partnering, sort of co-developing interventions with patients, with community members, because they can guide us in terms of what is most important. So when I'm thinking about what outcomes are most important, I want to hear directly from patients. I want to hear directly from community members around, what are the outcomes that they care about. We focus a lot in sort of the academic literature around reduction of emergency department utilization, reduction around hospitalizations. But I really want to know what are the patient-oriented outcomes that we should strive towards. And when we ask our patients and our community members, we may learn about other opportunities around what I've heard when I've done this is around sort of quality of life, the ease of navigating services in healthcare, things like that I think we could, focus on and do a better job on.
Yeah, no, that's great. Thank you. So another question that we have is from Amy McElroy, who is in the office of Assembly Member Robert Rivas. Her question is, what state policy recommendations do you have coming out of this study? I'll take that one. One of our, and we've mentioned this a few times now in this presentation, is really trying to harness the different administrative data sources. Hemal mentioned triangulating available information, so we really can have more robust data sources and information sources that can help us to, say, monitor and evaluate different programs, different funding infusions, and that sort of thing moving forward. Hemal had mentioned Cal-AIM, which is a major initiative in the Medi-Cal program, which really has introduced new benefits around enhanced case management. It also has community supports that do include some housing assistance. And so we really, as we continue to kind of move forward and have more resources going to addressing homelessness, we do need better information sources to kind of monitor and track and evaluate those investments. The other thing I would add is, we've mentioned SB 1152, which was a law that was passed. It has, again, kind of just heightened the awareness and the screening of people experiencing homelessness, but it provided no additional funding to either hospitals to do this work, nor to the communities to make sure that they have those things in place. And so, again, thinking about maybe Cal-AIM and other investments going towards this, how can we really support our hospital and our hospital EDs in order to, be able to serve this group of really vulnerable Californians?
And then Shannon, I would just add, so I think there's definitely policy recommendations that Shannon mentioned around sort of the data and improving our data. I would also say, and I sort of alluded to this earlier, but some of the policy recommendations around housing are also critical. And, in that I'm thinking about support for renters. I'm thinking about, eviction prevention. I'm thinking about sort of legal and financial support for tenants. I'm thinking about access to low income housing, to affordable housing that's permanent. Those are, again, things that I think are really needed from a sort of federal and a state level to support sort of anti-homelessness efforts that I would, love to see more of. And I think we've had some success across the state as part of sort of economic relief efforts or COVID-related, funding that I think I would love to see sort of continue and grow to eliminate and prevent homelessness.
No, thank you for that. Yeah, thinking, or in our report does focus kind of in this health services space, but it's a very good point that kind of all of the things around increasing housing supply and increasing housing supply for people with lower incomes, providing permanent supportive housing, and all of those things really are, just inherently crucial to kind of addressing any of this. It looks like we have another question from Jim Burkett with the Department of Healthcare Services. Does this information include patients who were treated and released from the ED and therefore never admitted or discharged? So yes, we are able to see both in the discharge data. We do see both patients who visited the ED and are treated and released the same day. It's still considered a discharge. It's just a discharge from the emergency department. We also are able to observe patients who came through the emergency department and then as a result of their visit, were admitted to the hospital for further care. And so we observed both of those in this study. You asked this in the context of, kind of undercounting. I did mention, because of the challenges that we heard about identifying people in the emergency department setting, these are likely, even, the visits that are, the people that are identified, it is still likely undercounts, and so it's important, but we do observe people who only make a same day or what we call outpatient visit to the emergency department. Let's see, here's another one for Dr. Kanzaria. What have you seen firsthand during COVID-19 as to the pandemic's effect on people experiencing homelessness?
Okay, yeah. I think that, I was concerned like many others in terms of having a pandemic like COVID on top of a a crisis related to homelessness. And so it also it did provide an opportunity for sort of creative and innovative sort of solutions and partnerships between healthcare and non-healthcare agencies. And so, for example, in San Francisco, when the pandemic started, I think there was concerns about either discharging people from the ED to themselves when they had potential COVID. Again, those were in the days where testing took a week, or we didn't have access to tests, or admitting patients with sort of low acuity symptoms because you were afraid of propagating, infectiousness and the pandemic. And so, what our city and county was able to do was partner with other agencies, including the Departments of Homelessness and Supportive Housing, the Human Services Agency, and throughout the Department of Public Health, to stand up hotels in San Francisco. So we had isolation and quarantine hotels that we were able to, provide great care, including harm reduction services, including sort of food, family support, care coordination, and substance use disorder services for clients in a hotel environment. So with medical staff that allowed for safe isolation and quarantine outside the hospital while preserving, again, enough hospital capacity for patients with, significant medical disease. And I think the reason we were able to stand those up within a couple of weeks of the pandemic starting, and that was so critical because, again, learning from the experience of, or seeing the experience of China and Italy and New York City early on in the pandemic, excess mortality from COVID was related to, healthcare being over capacity. And so I think in San Francisco and across sort of the state, we've had examples of success with that. I will say on another side, there's been a lot of efforts around sort of building trust, community partnerships to sort of dispel some of the misinformation related to COVID vaccines, for example. And I keep on coming back to sort of meeting individuals where they're at. And so part of that was, we were doing vaccine related efforts from the emergency department. So again, public health interventions based in the emergency department here to ensure that patients had access wherever they were. We were also outreaching to our community and going to our community and holding sort of testing events and vaccine events specifically for patients experiencing homelessness. A lot of that effort was led through UCSF, BHHI, and Dr. Margaret Puchel, one of our co-authors, as well as multiple other agencies partnering and with collaboration with the Department of Public Health. So lots of sort of opportunity. I think there's still a long way to go in terms of information about vaccines that are coming out now and ensuring that our population can be as healthy as possible.
No, that's great. Thank you. And you mentioned Project Room Key, or where you are able, where the state did use federal dollars primarily to find hotels and motels and places where people experiencing homelessness could shelter in place or recover from an illness. And there have been a few studies that have come out that have shown that really did have some important implications on, say, emergency department use and some of these other outcomes that we often look at, right? And so it does feel like, some of what happened during COVID could help us to learn about what we may be able to do in the future. So we've reached the end of our program, and I would really like to thank you, Dr. Kanzaria, for joining me today, and obviously also for just being a key contributor to this study. I would also like to thank our funders, the California Healthcare Foundation, and finally, thanks to all of you for joining us today online. If you pre-registered for this event, later today you will receive a survey. We would appreciate you taking a couple minutes to respond to let us know what you thought of this event. And please have a safe and good afternoon. Thank you again.